Good morning, everyone, and welcome to the online ART training offered by the American Center for Reproductive Medicine at Cleveland Clinic. Today is Tuesday, November 10, 2020, and we are going to be covering Module 1A on semen analysis. My name is Ashok Agarwal. I am the host of this program for the next 2 hours. So welcome to all of you, and we are ready to begin now. I want to declare that we don't have any conflict of interest. As you can see, the program was completely organized by the support from our center, and no companies or outside entities were contacted for any kind of sponsorship. Webcasting was supported by our Cleveland Clinic IT division, David Reichling and David Wolfley. Course faculty have donated their time for this online training. Program coordinators, and we have 7 of them who have volunteered their time for this training. And more importantly, the names, images, and description of certain products or instruments which you will see during the lectures are being used routinely in our andrology lab, and we are not endorsing any of these as speakers. So let's talk about the genesis of online ART training. How did this idea of online training really started? I believe the truth is that because of the pandemic, we were trying to think out of the box what we can do to provide a kind of training which will be useful for people all over the world. And we came out with these ideas, which we worked out with our team. And the goals were offer the highest quality educational experience in human reproduction on a global level using an online content delivery model. Second, to raise the bar on the quality of lab skills and theoretical knowledge in andrology and ART, which is extremely important for the practitioners and laboratory workers all over the world. I think these are the 2 most important goals that we had. And you can see the model here, which is shown in this cartoon. We have the speakers and coordinators connecting through WebEx, electronic mail. We have WhatsApp, which really helped connect everyone. We created 5 groups, each with about 250 candidates, and they were managed by our team of coordinators, and all the documents were saved on Dropbox. So we use these technology to have to connect with all the participants who are interested in joining our program today. The online ART training course that we have planned for 8 modules, which will be covered in 14 virtual sessions, all the way from now all the way until December of 2021. There is free registration for all of them. Candidates who complete the test, and which we will explain, will receive certificate of participation. And our faculty are mostly experts in andrology and human IVF, either from the Cleveland Clinic or those who are going to be invited by us. The program will include lectures, very focused lectures, done in a very different way, in a very practical manner, so that the listeners and the audience are able to really understand the nitty-gritty of details of how they can use these information on a day-to-day basis. The program at the end will be complemented by multiple choice questions, which will be coming from the content that will be covered during this 2 hour of program. So it is very important for all of you to listen carefully to the program and the speakers, because the questions that will come in multiple choice, which we will explain later on, are not going to come from anywhere else, but from the lectures that we are going to provide. And we have provided in advance a lot of reading material, which is kind of going to create a basis or a foundation for many things that you are going to be reading, you are going to be listening today, as well as technical protocols, which you are freely shared with all of you through Dropbox. So I hope some of those were seen by you. So the topics, as you see on the right side of the figure, are going to start from routine semen analysis. Then we have advanced sperm function test, then a number of embryology related procedures, which will culminate in the complete cycle of all the procedures that are done either in andrology or embryology lab. We have been working in this area for a number of years, almost 17 years. We have been providing ART training to candidates from all over the world. So we have a track record in providing actual training, but this is the first time we are offering it in a virtual manner because of the conditions that are there. So I hope the program will be successful, and we look forward to your feedback later on. Today's participant, we have almost 1,400 registrants belonging to 66 countries. So most of this announcement about the program was done on LinkedIn, and most of the candidates have applied seeing those announcements from the LinkedIn. The conditions for certificate of participation, there is no certificate of attendance, but there is a certificate of participation. And the main requirement for this is that there will be a multiple choice test, which will be offered immediately after the program, the scientific program is completed. Today we have 48 questions, and there will be 30 minutes given. We had budgeted about 20 seconds, so the plan was to give you approximately 24 minutes, but we are giving 6 extra minutes to allow you to check your answers. There is no penalty for wrong answers. There is no negative marking, so please feel free to answer all the questions. Those candidates who pass the test, and if they score either 60% or greater in terms of the correct answers, the results will not be available immediately, but will be relayed to you in several weeks. Followed by the multiple choice, there will be a link to the online survey, where the attendees will be asked to fill out an online survey, and this will be at the end of each module. And they also will have an opportunity to ask questions from the speakers, because there will be space after you look at and rate the quality of the speech from each speaker. You can ask questions, which again will be answers to those will be relayed to you later on. Survey results will be used by us to improve the organization of the next module. So this is very critical for us. Here are our program coordinators, Dr. Manesh, Dr. Sarah Madani from Algeria, Camila Pompou from Brazil, Dr. Neha Singh from India, Dr. Masha Darbandi from Iran. Then we have Andrea Bello from Brazil, Dr. Sara Darbandi from Iran, Raha Sadeghi from the States, and Renata Finelli, originally from Italy, but now she joined us in Cleveland Clinic last week. So these are the backbone of our program, and I want to thank all of them, and we'll thank them again for their wonderful cooperation and collaboration in managing this huge program and logistical details which you all experienced. So today's program is going to be including module 1A, which is manual semen analysis, which you have seen in the announcements that we have provided you. So the module 1A will start with safety procedures for laboratory personnel. Then we will talk about the collection and delivery of semen sample, discuss routine semen analysis, talk about computer-assisted semen analysis, then review quality assurance method for semen analysis, then proficiency testing. All of these will be covered one after another, and then we'll conclude the program hopefully within 2 hours. Our speakers today are Megan Caraballo, Dr. Gupta, Dr. Sejal Gupta, Dr. Rakesh Sharma, Alyssa Giroski, Courtney McNulty, and Dr. Neil Parekh. I am in charge of the Andrology program at Cleveland Clinic. And I'm also the director of the American Center for Reproductive Medicine. I wear a couple of different hats. I am very much involved in managing the diagnostic lab of the Cleveland Clinic, as well as our program in male infertility research in Cleveland Clinic. We are recognized as the #1 program in the world in the fields of male infertility, andrology, and human-assisted reproduction. And this is based on the number of peer-reviewed publications, based on the number of citation scores that we have, and also based on the H index. And these are the numbers that anybody can check anywhere in the world. If you go into Scopus database that rates every single researcher or author in the world. We have a large number of medical textbooks that we have written. More importantly, our program has trained over 1,000 scientists, clinicians, undergraduate students from the United States and from all over the world. So I'm very fortunate to be running this program along with the very talented team of people who you will meet some of them today. I spent about 10 years at Harvard Medical School, where I was the director of male infertility research in urology at Brigham and Women's, and also an assistant professor at Harvard Medical School. So now let's talk about the program. That is enough of my introduction. So we are going to cover about the COVID-19 crisis and its impact on Andrology lab. And this is the first very important lecture because I think the COVID crisis has really touched each and every one of us in every single part of the world. So if you look at it, this is the coronavirus, which really is affecting us. It started, this infection, it's a class of SARS-CoV-2 virus, started back in November, December of 2019. And it was then after a month or two declared as a pandemic by World Health Organization. According to the statistics in the last few days, there are more than 48 million cases around the world which are affected by this very dangerous virus. It's highly infectious, and more than 1.2 million deaths. Just in the United States, we have more than 10 million people who are affected by this virus, and over 220,000 people who have died in this country. Around the world, more than 218 countries have been affected by this virus, which we know started in Wuhan in China. There are conflicting reports about the presence of this virus in male reproductive tissue. We really have very little information which we can tell right now. The thing that we can say, only one study has found SARS-CoV-2 RNA in semen, while several other studies have reported no positive detection. So these are some of the studies which have been published looking at COVID-19 pathology and male infertility. So is the coronavirus one which can be transmitted through semen? Really, the evidence is not very solid. It's the presence of viral mRNA is seen in a very small percentage of infected patients, although few studies with limited sample size were performed. So the data is very weak at this time. The ACE2 receptors, which play an important role in the entry of this virus inside the cells, such as spermatogonia, Leydig, or Sertoli cell, have significantly higher expression of this receptor. And there is a possible involvement of Sertoli cells with the coronavirus, and that can lead to the impairment of blood-testis barrier. And the infected patient have been shown higher LH and lower testosterone LH ratio, which perhaps indicates a possible initial gonadotoxic effect. There are other findings which have come out in a small number of studies. Again, increased DNA fragmentation seen in COVID-19 patient due to inflammation in testis as a possible complication of this virus. Consequent increase in the levels of reactive oxygen species or oxidative stress and psychological stress due to the infection. So there are so many things that have been discussed, but the bottom line is that the evidence is very small from very small number of studies with a small number of subjects. So all in all, the data that we see at this time is very weak. In response to this virus, CDC, which is the central agency called Centers for Disease Control and Prevention in the United States, came out with its guidelines for handling and processing specimens associated with coronavirus disease. And then a host of organizations, which are professional organizations, specifically in the reproductive area, such as American Society for Reproductive Medicine or European Society for Human Reproduction and Embryology. They all came out sometimes in March, April, May, a number of guidelines, position papers, which have been continuously updated as more and more evidence and more knowledge about this complicated virus became available. So there is a number of things that they have provided in these guidelines. And in addition, the Cleveland Clinic put together a host of information in their COVID-19 toolkit on our internet. And right from the day one, they have been providing a wealth of information, guiding all the employees and clinicians and staff who are working at the Cleveland Clinic in terms of the best practice guidelines. So these guidelines, along with those issued by the Center for Disease Control, the World Health Organization, the Department of Health in Ohio, and the Cleveland Clinic, really have offered us the foundation for best practices, which have been developed by our group of staff here and employees in our Andrology lab, which we are going to discuss in the subsequent slides. So from this slide onwards, the actual talk was supposed to be delivered by my colleague here, Megan Carabello, but unfortunately she has a sickness in her family and she could not join. So I'm going to cover this part, which is the objectives of this talk is to talk about the preventive measures, the safety guidelines for patients, laboratory testing and fertility preservation that can be done during the era of COVID, and what are some of the important messages for all of you who are practitioners or laboratory professionals interested in reproductive medicine or reproductive sciences. So looking at the symptoms of COVID-19, the major symptoms of COVID-19, which appear anywhere from 2 to 2 weeks after the exposure, include fever, chills, cough, shortness of breath, fatigue, muscle or body ache, headache. So all of these symptoms really precede the actual full-blown infection. So I think those are things that we all need to know. And these are being very well explained. Here at the Cleveland Clinic, the institution created a app or an applications where the employees are required to self-screen prior to reporting to work. So this is a fairly simple app that we can all download, and we enter our information, log in, and then we report if we have any kind of symptoms. If we have no symptoms, then we log in, and that it gives you a COVID pass telling you as an employee you are clear to go ahead. You don't have any symptoms, and you can go ahead and start working. So the employees are required to self-screen prior to reporting to the work. And COVID-19 pass is really intended to give the employees and staff the opportunity to reflect on their own health status as it relates to COVID-19 symptoms. If they do report a symptom, then they report, then they can go to the employee health and get proper evaluation and medication as required. The employees are also screened every single day by thermal scans in every single area of the Cleveland Clinic. They are required to wear the face mask. I'm not wearing right now because it'll be hard for me to speak, but this is my mask that I have to wear right from the time that I come out of the garage of the car in the Cleveland Clinic lot, everywhere in the neighborhood and in every single building until I leave from the premises and area of the Cleveland Clinic. So this is a requirement. But more importantly, if the temperature shows above 100.4 or higher, then they will be asked to go to the clinical triage area and see a nurse or a physician, and they have to report. Otherwise, they are clear to work. Now, in terms of additional patient screening for scheduling and visiting, these are the guidelines that we have developed based on all the guidelines which are available. As you know, that many of these large organizations, whether it is WHO or CDC, ASRM, ASHRAE, they give hundreds of scenarios and options, but you have to choose and create something which is specific for your own patient, for your own employees. And that takes time. So you cannot just try hundreds of things. It will make everyone go crazy. So it takes time to develop things which are really customized for your own area. So here, for our patients and visitors, we ask a set of screening questions to really identify the symptoms and risk of COVID-19. The standard questions that we have are, have you been in contact with someone who has been confirmed or suspected to have COVID-19? Do you have any new or worsening symptoms of COVID-19 today? Have you had a COVID-19 viral test within the last 14 days? If yes, please provide the result. Have you traveled internationally in the last month? If yes, please provide the location. So these are questions that every single patient has to answer, and all of us, when we are scheduling a patient for an appointment within the andrology program, these are questions, but these are questions that are asked by all schedulers in every single department within the Cleveland Clinic. So these are very, very important questions, and these really tell us if these patients are symptom-free and they don't have any kind of risk, and they can be actually scheduled for a visit in a different department. Now, in terms of the preventive measures that we have formulated for employees as well as for physicians, first for the employees, to make sure that there is no risk of COVID-19, are making sure that there is a personal space or there is enough room for people to work, at least as recommended by CDC. There is personal hygiene, that employee cover their mouth when they're coughing or sneezing, wash their hands, wear face covering. They should not touch eyes, nose, or mouth. Stay home when they're sick. Use hand sanitizer when washing is not available. Clean and disinfect frequently touched objects and surfaces. So these measures are well described in the media, in all the guidelines that you all must have heard. So in terms of the specific steps within the andrology area, we clean and disinfect all our surfaces with EPA or Environmental Protection Agency's approved disinfectant prior to the first patient being seen in the andrology lab, in between and after each patient and visitor, and also at the end of the day. So in other words, you have to keep on cleaning multiple times. You have to clean the laboratories, you have to wipe the waiting areas, you have to clean the collection room. Of course, we have cleaning staff as well for bathroom areas, office and consult room, lunch room, and common space. So our employees are going around, our staff are going out and cleaning each and every area. And this is something that is done multiple times during the day using a variety of disinfectants which we are using. These are variety of bleaches which can kill all kinds of germs and viruses. So we have the more important thing is the contact wet time. This is the amount of time a surface must remain wet when you spray the disinfectant. So you do not want to clean after you spray, you let it wait. And in terms of the contact wet time, each of these products that you see and others that you may be using specify whether it is 1 minute or 2 minutes for it to soak in and do its work on the germs that are spread around or touching all these surfaces which patients or employee may be touching. So this is very important, is not only to spray, but let it soak in and then wipe it nicely. Now, in terms of the spatial recognition or social distancing, there is a 6-foot distance required at all time, and that we have pasted the signage throughout the facility as a reminder, and you will see it on the walls, on the carpet, on the chairs, in every single place to remind people working or the patients that they need to maintain this social distancing of 6 feet away from everyone. The chairs are being taped, just leaving some chairs, so there is enough space between when the patients are waiting. And also there is lab employees are spaced out within the lab. To minimize the infection, the lab should remove all non-essential items, whether it is coffee supplies, whether it is magazine, all of those should be removed at this time. They should not be kept to clutter because they will collect germs as well. Now, in terms of the hand washing, you probably heard of it, and the most important is to clean with the soap and water, and clean thoroughly, not just to clean in a very quick manner. And we have to, of course, use the PPE, which will come next. So you have to clean your hands when they're dirty or contaminated, before eating, after using the restrooms, and then you can also use the alcohol rub when hands are not visibly soiled or upon entering and exiting a patient room. So these things are extremely important in maintaining that you can avoid any kind of infection or have any kind of touch with the viruses. So the other important feature of this is the personal protective equipment, or PPE. And the most important recommendations which are mandatory at the Cleveland Clinic are every single doctor, every single nurse, every single employee, every single person in the family of the Cleveland Clinic and its various hospitals, more than 70,000 people around the United States and around the world, must wear the face mask every single day at all times, every single time. They should also have protective eyewear with the protective glasses or face shield where there is a possibility of any kind of aerosol. They must wear the lab jacket or lab gown, which should be disposable, and they should wear the gloves. For the patient and visitor, they must have the face mask. If they don't have that, you can provide a face mask, or we provide a cloth mask. So the patient who are entering into our facility must wear the mask But if they are not carrying it, then we provide that to them. Universal precaution and biological safety are very important approach to infection control, to treat all human blood and certain human body fluid as if they are known to be infectious for all kind of infectious diseases such as HIV, hepatitis B, and all other blood-borne pathogens. And we really need to use the biosafety practices for patient samples that are positive for various types of infection, COVID-19 positive patient, and also for semen cryopreservation is pump banking samples. And they should be performed under a biological safety hood, which is BSL-2 hood. This is a special category of hoods that are categorized for use for these kind of infectious conditions. And in terms of the actual types of waste disposal method, the biohazardous trash, which you see on the right side with a large container and a red color biohazard bag, at least in this country, are used for all kinds of things such as towels, linens, collection containers, condoms. And then we have pipettes, pipette tips, soil lab jacket, gloves. And then we have the sharp container, which is used to dispose, which is on the bottom of the right panel, used to dispose all glass products, needles, and metal products. So those should go into very specific containers. Once they are filled, they are locked, and then they are sent for disposal through the Cleveland Clinic biological safety disposal team. Another important aspect which has been created at the Cleveland Clinic is this 4-color coded visitation level. This really is important because current status here at the Cleveland Clinic is red, which means no visitors unless special assistance is required. Only patients should be allowed. And we in the andrology use the staggered appointment times, so giving enough time, at least 1 hour for each patient. Unlike in the previous time when we can have 3 or 4 patients within 1 hour, we changed our practices back in June of this year when the lockdown was lifted, that only 1 patient per hour. So we staggered to give enough time for the patient to arrive, go through the process of provide us the sample, and leave comfortably before the second patient comes. So there is very little or no overlap between the first and second and the third patient. And we don't allow any kind of accompanying person, the wife or family member. They should sit outside in the car, but they cannot enter within our premises to protect them as well as all the employees. So the take-home message here is really that yes, there are very few reports of COVID-19 in semen, and with a very small sample size, while other studies have failed to document this finding. However, we cannot minimize the dangers of coronavirus. It is a highly infectious virus, a very highly infectious and dangerous virus with a very high degree of fatality, certainly in the older group of patients, but also in as well as in younger patients we are seeing. So, and more importantly, we haven't really seen good studies with large sample size. So I think prudence and precaution is really mandated. We can still provide andrology services at this time in a safe environment. We encourage the use of PPE, or personal protective equipment, social distancing, and screening of employees. Using patient and visitors mitigates the spread of coronavirus. So I believe that we have to provide the services to our patients, whether it is patients of infertility, patients who are cancer, who are the most vulnerable group and who may have a very small fertility window. And this is the consensus of an expert group are drawn from all over the world, which was published a few months ago under the leadership of Dr. Sandro Esteves. And the group actually provides the blueprint for opening up. It has been several months that this article was published, and allow andrology services to be provided in a safe, careful manner to the patient who really require these services with us at this time. So I want to thank my team here and many of our colleagues and trainees. These are many of our past trainees who came in front of the Andrology Center. The picture is in the front of the Andrology Center. And this is a picture of the Cleveland Clinic that you see here. A beautiful spring day. And one of our institution here, the big building, represents the cardiac center of the Cleveland Clinic. So thank you very much. This finishes the first talk. And now I will introduce the second speaker. So bear with me for a I want to now introduce the second speaker of the program. This is Dr. Sejal Gupta. Dr. Gupta is the technical supervisor of the Andrology Center and the reproductive tissue banks for over 12 years. She is a trained OBGYN, have done fellowships in reproductive medicine, as well as in the research. She has earned a number of awards, and she is also an assistant professor in the Cleveland Clinic, and she is the leader of our andrology lab. So I want to ask her to begin her presentation, and she is going to be speaking about the quality control in an andrology lab. Dr. Gupta can present now. The control of this program is, the slideshow is being done from my office, so I will move the slide when she tells next. So Dr. Gupta, Sejal, you can begin the presentation.
Thank you very much, Dr. Agarwal, and welcome to all the participants. It's my pleasure to speak today on the topic introduced by Dr. Agarwal. And the learning objectives of my topic are definition of quality control as it is applied to a male infertility evaluation or an andrology lab, quality control in the 3 phases of testing. So on the right side, I've provided an example of a laboratory workflow where the 3 phases of testing are shown as pre-analytical, analytical, and post-analytical. Then the significance of quality control, and finally, a few key take-home points. Next slide. Next slide. So let me define quality control for you. Quality control allows the lab to establish quality indicators for the lab equipment, the procedures or the standard operating protocols, the technologists who are the testing personnel, and thus ensuring that they meet the established criteria of accuracy. So how is this achieved? Basically, quality control includes all activities or operational techniques which are carried out to meet the quality requirements for a particular process or a product. So just to give you an example and make it a little interesting, a product could be from a manufacturing unit like a Mercedes-Benz car. So every time we go to the showroom, we get a perfect car. So there are processes in place which ensure that the quality of the product is excellent. And for the male infertility evaluation lab, it is the test results or the processes that are involved in testing which should meet the quality indicators, and the lab has to set up quality indicators or benchmarks for each of the process to ensure that we are meeting the quality control criteria and that the results that the lab is reporting are accurate and produced efficiently. So the elements that the quality control gets applied to is the equipment. The equipment has to be of the right functionality. You can see in the first blue box, and there are steps that you conduct every day, including daily quality control checks, calibration of the equipment to make sure that the equipment is functioning correctly. The second element is the standard operating procedures or the protocols. So all of the procedures that are done, and this applies to all processes within the lab. It includes having a standard operating procedure for quality control itself, for all of the tests that are done within the lab, and delegating the various functions within the lab. To provide an example, I have shown that for semen analysis assessment, the technologist or the testing staff has to follow a standard procedure and do it as it is laid out and broken down into steps within the procedure. Also, within the SOP, you have the reference ranges. So the reference ranges are provided as per the WHO 5th edition guidelines in the male infertility evaluation lab. The technologists are a very important element of the testing process, and it is necessary that the technologists are trained to a high standard. And why is this important? Because you want to ensure that your technologists are competent and they're producing the results which are accurate and precise. So how do we test the training of these technologists? We do what is called annual competency checks. And I will be providing, to make this presentation more interesting, I will provide actual examples of how we do the competency checks. And then there is external quality control, which is the proficiency testing. And the proficiency materials are sent by certain accreditation bodies. In the United States, we have the College of American Pathologists, from whom we receive these analytes twice a year, and these are tested by the technologists to assure that the testing process within the laboratory is being conducted correctly. Next slide, please. So this is an actual example of a competency checklist, and this is as it applies to the basic semen analysis procedure. And all of the procedure is broken down into steps. The first being we quiz. I, as a supervisor, conduct these competency checks because I am deemed by the accreditation agencies to be competent to conduct the competency checks for the technologists. So how do I do this? I directly observe the technologists while they're performing the test. I quiz them. I look at each step, and all of the steps are listed here: the macroscopic examination, the microscopic examination, and I check all steps all the way through to make sure that they are performing correctly, and then also provide them with some constructive feedback. Or if they are lacking in any area, then I give them feedback. Like in the first box, you see the comment that they need to review more in details the criteria for counting the cells. Next. So once they have been checked off on all the components, they are classified as competent in performing the basic semen analysis test. But if they have failed, then I will go back and redo the competency assessment, and only after they have been deemed competent are they allowed to do the testing in the lab. Next slide, please. So quality control is defined as being applied to 3 phases of testing. So the pre-analytical phase, analytical, and the post-analytical phase. So here, the first phase is before the patient comes to the lab. He will go to the physician or the male infertility evaluation consultant, and he will consult, and the physician will arrive at a diagnosis. It could be primary infertility, it could be secondary infertility, or whatever were the findings or the history, depending on that. And then the physician orders the test. So the physician could order a semen analysis or some ancillary tests based upon the reproductive history and the examination, like a retrograde sperm count. So the second component is the actual testing, which is the semen analysis, and we will perform as per the orders from the physician. And then finally, based upon the semen analysis, the sample will be classified as normal or abnormal semen quality. And this is done per the WHO 5th edition guidelines and meeting all the regulations of the College of American Pathologists, as well as other accreditation bodies like FDA, Food or Drug Administration. And this is achieved by continuous quality control monitoring on each of the steps along the way. Next slide. Each lab has to set up the quality tasks. So each lab can set up schedules on a daily quality control, the second weekly quality control, and monthly quality control. And I've just provided a few examples, like our daily quality control is the first thing we do in the lab is count the QC beads, which is the quality control beads for sperm concentration in a counting chamber. And once we meet the criteria for accuracy, then the lab is ready for testing for that day. And to give an example of weekly quality control, testing the IVR stations, making sure your employees are safe in the lab, monthly quality control of doing checks of the inventory or checking and removing any expired reagents or supplies. Next slide, please. So what are the three analytical indicators or benchmarks for quality control? On the left side, I provided examples of some of the indicators looking at incorrect test requisitions. The physician has ordered a sperm count instead of semen analysis for infertility evaluation. So this is an incorrect test because it will not provide the complete evaluation that is necessary for infertility evaluation, or there are no orders, or the physician did not add a diagnosis code. The second indicator is the patient appointments. So we need to monitor within our lab the delay in getting patient appointments, or the patient has a long waiting time in the lab. And this may lead to patient complaints. So this is an important quality indicator to be monitored for an andrology lab. On the right side, you can see there is a graph that I've depicted, and this is a patient satisfaction survey on the length of time for an appointment within the andrology lab. So we see that 50% of the patients, we exceeded the expectations, 45% of the patients, we met the expectations. So this is an excellent result, with 95% of the patients being very satisfied in terms of getting the appointment. The third criteria that needs to be examined for quality control is specimen rejection criteria, and it includes delay in transport or the sample not being labeled with 2 patient identifiers is an immediate cause for specimen rejection. Next. Going on to each lab must have a documentation of their specimen acceptance and rejection criteria. And these apply to the sample collection container, the transport conditions, and time to analysis. So I have provided some of the reasons that the sample can be rejected if it's a non-sterile container, or the collection container failed the toxicity testing, or the time to analysis is more than 60 minutes because the results will be suboptimal. Next. Next slide, please. Another element which needs to be examined is the quality control of reagents in an andrology lab. Here on the right side, I've shown quality control for gradient media, and we had an old lot of the lower phase, which we have compared with the new lot of the lower phase. So we always compare the old lot versus the new, and then we split the sample and run the gradient media preparation, and then we examine the % recovery of the total motile sperm. So we calculated, and the % total motile recovery ratio is then examined. And in the red box, you can see that the acceptable gradient media quality control, the % recovery of the total motile with the new lot is, the ratio is examined to the % total motile recovery with the old lot, and this needs to be greater than 50%. So this is our quality indicator, and the ratio was 92% in this case. So I have reviewed on the right side, and then I have passed that this lower phase is ready to be used in the laboratory. Next. Analytical quality control is the second step in the process of testing. So here, instrument function checks need to be done with the incubator, the temperature checks, the ambient temperature, checks, the pipette calibration, and the most important is the training, competency, and proficiency of the technologists. So the technologists are trained in the standard procedures. I provided an example earlier in my slide for the competency criteria, and they are assessed on the competency. Next slide. And here I have shown you a standard operating procedure, which we have shown, which we have shared with you on the Dropbox. It is a SOP for the basic semen analysis. So each of the steps has been broken down with the purpose, the instructions for the patient, the specimen collection and delivery, and each of the steps is broken down for your review and understanding as to how important a procedure is in analytical quality control. Next. The instruments that are important in conducting a semen analysis, the pipette calibration. If it is not performed, an incorrect sample volume can be loaded. And as a result, on the second box, there is an impact on the sperm count and motility, and there will be an error in estimation of the count or the motility. On the right side, I have provided an actual example of pipettes that were calibrated in a lab with the coefficient of variation less than 10%, and then the pipette can be used in the lab. Next slide, please. Quality control of the incubators, the temperature checks, the humidity checks, because the temperature will impact the sperm motility. On the right side is an actual example from the andrology lab at the Cleveland Clinic. The range is provided 36 to 38. Each day you can see how well the quality control has been documented, and weekly quality control that is performed is also documented. Next. Reagents have to be stored as per the manufacturer instructions, either at ambient temperature. On the table on the left, you see the AccuBeads have to be stored at ambient temperature. The anti-sperm antibody testing control sera have to be refrigerated. So we monitor the ambient temperature as well to keep the reagents in the required range. Next slide, please. So for a semen analysis, the quality control for the sperm count is paramount. It is of extreme importance. And how do we test the reproducibility of the sperm count? So the procedure is to do the known concentration of latex beads or AccuBeads, and these come in two ranges, the low and the high. And on the right side, I've provided an example from the andrology lab at the Cleveland Clinic of a Levi-Jennings chart. So what is plotted in this chart is the AccuBeads high value is plotted on the y-axis, and each day of testing is plotted on the x-axis. So the mean is calculated, which is the blue line, and then the yellow lines indicates the plus minus 2 standard deviations. On each day of testing, the concentration values for the high quality control beads are within plus minus 2 standard deviations, indicating the lab process is working well and there are no definite deviations. Next. I also wanted to show you an example of a deviation. This is a more elaborate record of over 100 days of testing of, again, high concentration beads. And in the red box, I've shown an example of a deviation. So what is this deviation? All of these values are less than the expected value, or which is the mean, EV, or the mean, and more than 10 values, if they are below the expected value, is a cause for concern, because it indicates a systemic error. And one needs to look at, if the technologist is not doing the procedure correctly, she may have to be retrained, or the machine is not performing well, then we have to recalibrate the machine. And till the time the quality control is met, the machine will not be used. Next. Sources of error in evaluating sperm concentration. So these are provided on the left side. You can make a note, you can review these and implement them within your lab. So your technologists are mindful that these are the errors that can happen, like incomplete mixing, dilution errors. And on the right side, I've provided an actual quality control from our laboratory, where we do weekly quality control with a normozoospermic sample, which is a normal subject or a donor. In the green box, you will appreciate that the manual count and manual motility is performed, and the same sample is then run on a computerized assisted semen analyzer, and the agreement between the manual concentration and motility and the CASA machine concentration and motility, and we actually did it with 2 machines, there was a high correlation or a high agreement. So that ensures that we are doing the right steps and ensuring quality control in our sperm concentration assessment. The red box just to indicate that, documentation is everything for quality control in the lab. Whatever is not documented is not done. But we wanted to just highlight during the COVID period, we couldn't do the quality control, and this was documented. Next. And some more sources of error, like improper mixing, or the last box, it's the most important, inter or intra-technician variability. So how do we assess that the technician is performing well? By looking at inter-technician variability. And on the right side, there is a Bland-Altman plot where 2 technologists performed sperm motility assessment on the same samples. And then we have plotted the average total motility versus the difference in motility on the y-axis, and the mean and 2 standard deviations. The mean is the white line and the red dashed line, so the plus minus 2 standard deviations. And all of these values are within plus minus 2 standard deviation, showing that there is a high agreement on sperm motility assessment between the 2 technologists, and both technologists are performing well on the testing process. Next slide. Some more sources of error in assessing sperm motility, like conditions impacting sperm motility, temperature change, subjective bias. A technologist has subjective bias and is producing consistently high or low percent motility values, technical errors. They must avoid counting the chamber, the sperm at the edges of the fixed cell chamber. Next slide. Next slide. And then the last component is the post-analytical quality control. So how do we assess and what parameters we have set? So for this, we check the calculations. On the right side is a semen analysis worksheet from the Andrology lab at the Cleveland Clinic, and all of the parameters are checked, the calculations are checked. If there is any missing information or if the calculation is not correct, then we make that correction. And then once the results are okay, it is signed off. Next. These results are then manually transferred into electronic medical records. And this is a printout from the electronic medical records. And these are also reviewed and released to the physicians only after they have been validated, and any corrections that have to be made are made. So if a correction is made, then in the electronic medical record, it will show as corrected results, and these are preceded by the uncorrected results. Thank you. Next slide. More indicators for post-analytical quality control, monitoring test time to analysis, monitoring the test turnaround times. So on the right, there is a table at the top showing gradient sperm prep review, and the time interval is looked at. It has to be less than 60 minutes, and all of the samples met this criteria. Or monitoring the test turnaround times, which is the threshold is in the lower box. You can appreciate less than 3 to 5 days, and all of the samples met this indicator. Next. So overall, the take-home message is to employ quality control within the male infertility evaluation to provide a high-quality semen analysis to all patients as well as the physicians. And so the physicians are confident of your results and can use it for diagnostic and therapeutic purposes to help the male infertility population group that they are seeing. And how is this achieved? By instituting strict implementation of internal and external quality control within the laboratory, which is also necessary for lab accreditation. I have highlighted several quality control tools that we use in our andrology lab at the Cleveland Clinic to achieve results that are accurate, reproducible, and reliable. Next slide. Next slide. So this is our group in the Male Infertility Evaluation Lab, and thank you for your attention. And this is our beautiful Cleveland Clinic campus. And I thank all of you for your attention. Thank you.
Thank you very much, Sejal. Thank you, Dr. Gupta, for a great presentation. Now we close this presentation. So I want to quickly introduce our next speaker, and that is Dr. Rakesh Sharma. Rakesh is an associate professor at Cleveland Clinic, and he is also the assistant technical supervisor in the Andrology Center. He has been with us for over 27 years, first in the research area, and then from last 2 years, fully into the clinical arena, managing our 3 andrology labs around Cleveland. So let me ask him to begin his presentation, which is on Manual Semen Analysis and World Health Organization 2010 5th edition reference value. Rakesh, can you please take over?
Sure. Thanks, Dr. Agarwal. So the topic that I'm going to discuss is Manual Semen Analysis and WHO 2010 reference values. Next slide, please. Next slide, please. So before we so the learning objectives that I will cover this morning are: what is the need for semen analysis? What instructions should be provided to the patient so that the sample is collected correctly? What setup is important when we are looking for the analysis under a microscope? What comprises the macroscopic as well as the microscopic parameters? How do we calculate the motility or the progressive motility and the sperm concentration? And then some key take-home messages, which include the WHO reference ranges, how these have been derived in the 5th edition, and what are some shortcomings. And then finally, the take-home message. Next slide, please. Before we dive into the semen analysis, it's very important to give you an overview of how the semen production occurs. Spermatozoa are produced in the seminiferous tubules of the testis. They are transported in the epididymis, where they are stored. And at the time of ejaculation, they combine with the secretions of the seminal vesicles and the prostate, which are the accessory glands. And this comprises the composition of the semen sample. On to your right, you can see the view of the mature spermatozoa, as well as the testis and the epididymis. And on the extreme right are the seminal vesicle and the prostate. Next slide, please. So the physician is evaluating the patient, and the first thing he will order is the semen analysis. And the semen analysis is done to essentially examine if there are sperm present in the ejaculate, because this provides the proof of spermatogenesis. On to your right is an example of the worksheet that we follow in our andrology lab, which highlights the information about the patient, the collection, whether the sample was collected completely or there was a sample lost, also the microscopic parameters as well as the microscopic parameters. And on to your right are 2 images of our andrology lab. Next slide, please. An abstinence period of 2 to 7 days is recommended. Samples should be collected by masturbation only. And in case the patient has some reservation, they can make use of a male factor condom. The collection container should have 2 specimen labels or identifiers. And if the patient elects to collect the sample at home, the sample should be kept at ambient temperature so that it is not exposed to extreme temperature. And the sample must be delivered to the lab within 60 minutes after collection. Next slide, please. Quality control is very important in the semen analysis, as Dr. Gupta also elaborated. The quality control includes the quality control temperature for incubators, the refrigerators, the ambient room temperature, the plastic were used, and more important, the quality control for sperm concentration. Onto your right is an example of recording the temperature for the incubator. And anytime the temperature fluctuates below or above the recommended range, proper steps must be taken to correct this action. At the bottom is the example of the quality control for sperm concentration. We make use of two latex concentrations, low and high, and this provides us the range in which the sperm concentration is expected. Next slide, please. Here I want to cover the microscopic parameters, and it is important that each lab has their own protocol and not just follow the WHO manual. Each lab should develop their step-by-step recipe so that the technologists who are doing the analysis can perform the analysis correctly. After complete liquefaction, we check for the volume, the color, the pH, and the liquefaction time. In addition, we also look for the viscosity, and if the sample is viscous, we will make use of some proteolytic enzymes such as trypsin. Onto your right, you can see the sample which is placed in the incubator, and then the sample is transferred from the collection container to the tube, and we check for the pH of the sample. Next slide, please. The microscope setup is important, and this involves the use of a phase contrast microscope, a 20x objective, the use of a green filter to increase the contrast because we are not staining the sample. The use of an ocular grid or a 10 by 10 grid is important. It is inserted in the eyepiece so that we can define the boundaries of the cells that we are counting. And the cell counter also is helpful when we are counting the cells. Onto your right, you can see a picture of our andrology lab. And next slide, please. Here I want to give you an example of how we load the sample and what kind of counting chambers we used. In this example, I'm talking about the fixed cell counting chamber, and one of the example is the two-chamber Leha counting chamber, which, as you can see, can load two samples. This is a fixed cover slip sample and has a fixed depth of 20 micron, and a 6 microliter sample can be loaded on each well. Next slide, please. Here I want to show a short clip where one of our technologists is getting ready to do this sample analysis. The previous slide, please. Yes. So can I have the clip, please? The technologist is labeling the tube in which the sample will be transferred from the collection container. And the first thing is to check the pH of the sample, and a small drop is placed on the litmus paper or the pH paper and checked for the pH of the sample. The next step is to vortex the sample. But before we do that, it is important that the sample is carefully transferred from the collection container into the graduated centrifuge tube using a serological pipette. And we check for the volume of the sample as well as the color of the sample. We quickly vortex using a vortex mixer and check the volume and the color. The next step will be to take a pipette and carefully load 6 microliters of the sample on one of the well. And this is done by checking that the sample is adequately loaded in the tip and carefully releasing the sample into the well. As you can see, the sample has completely spread, and it is important that we label the slide on which the sample has been loaded. Next slide, please. You have received the separate attachment where each step of calculating the motility and the concentration has been described. So in this example, I want to show quickly how the sperm motility and the concentration is derived. As a rule of thumb, if the sperm concentration is from 20 to 50 million, we will check the number of sperm present in 2 rows, and we will count the number of motile sperm which are labeled in blue over here, and then count the non-motile sperm which are shown in red over here. And then we observe the number of sperm counted in 2 rows. Next slide, please. So the example I will like to illustrate here is if we have a liquefied sample and we want to count 2 rows using a 20x microscope and an ocular grid which has 20 squares, then the first step we need to know is how do we calculate the row factor? And in the example I mentioned, we are counting the number of rows, which you can see in the blue box, and the number of squares for the 2 rows is 20. So the factor that we derive is a factor of 5. The next slide, please. So the example for calculating the total motility, we will count 2 rows and we will look for 5 random fields and count the number of motile sperm, which are in blue. And we count a total of 53 sperm in this example, as you can see in the second orange column. And then we will count the non-motile sperm, and this will give us the total sperm in the 5 random fields, which in this case is a total of 129 sperm. And looking into the box on the left, you will see that the percent motility can be calculated and shown as 41%. Motility is always represented as a whole number. Next slide, please. The WHO 5th edition also recommends that we calculate or we report the motility as progressive, non-progressive, or immotile. And the progressive motility is the spermatozoa which are moving actively, and they could be linear or in large circles. And the non-progressive motility is any other motility which does not show progression. And here I'm going to show you a quick clip where you will be able to see the fast-moving sperm with the blue track showing the path that they are moving. So in this way, we can calculate the total motility, which is the sum of the progressive and non-progressive motility, which is 40% defined by the 5th edition, and the progressive motility is defined as 32%. In many cases, we might find spermatozoa which have a poor motility, which is less than 40%. And in those cases, the condition is termed as actinozoospermia. Next slide, please. Here, we are looking into the calculation of sperm concentration. So going back to the previous example, we had a total number of sperm that we counted in 5 rows were 129. As you can see, the total sperm in the box on your right in orange color. And we can calculate the concentration by looking at the total number of sperm counted, the total number of fields, the row factor, the microscope factor, and using the total number of squares in the grid. And in this case, the concentration can be calculated and reported as 25.80 million per ml. It's important to differentiate the concentration from the total count. Concentration is always per ml, and the count reflects the number of sperm in the entire ejaculate. In many situations, we might find that the concentration of the sample is below the 15 million per ml cutoff, and in that condition, it is termed as oligozoospermia. And in other instances, the sperm may be completely absent from the ejaculate, and that condition is described as azoospermia. Next slide, please. Next slide, please. So I want to quickly touch upon how these reference ranges were derived by the WHO 5th edition. And in this situation, 2,000 samples were studied from 8 countries, and all the subjects in this data had accomplished the pregnancy in less than 12 months, and the standardized methods were used, and both progressive and non-progressive motility were reported. On to your right, I also want to highlight what are some of the key shortcomings in the WHO 5th edition. The most important is that the data is unevenly represented. The second thing is that it is very unclear if the low values reported in the 5th edition are due to the declining sperm count as reported in the literature, or it is because of the strict quality control. The next step is that these new reference values have resulted in a reclassification of many infertile patients who in the earlier editions were categorized as abnormal, but in this 2010 edition, they will all be falling into the normal category. Now, this creates a dilemma, especially in the clinical diagnosis of varicocele, whether the varicocele is in the adult patients or in adolescents. The question arises, how should they be treated? Who will be the candidates who will require the surgical repair? And many of these patients who were falling in the abnormal category now will be ineligible because they will be considered as normal as per the semen parameters. And therefore, this is an ongoing debate on whether the new reference ranges should be adopted with caution and if we need to revisit the WHO 2010 reference ranges. Next slide, please. This slide shows the normal reference ranges described in the 5th centile criteria. And as you can see here, the volume is 1.5 ml, the sperm concentration of 15 million, the sperm count per ejaculate of 39 million, the total motility of 40%, and a progressive motility of 32%. Any values higher than this will be considered as normal. Next slide, please. So the main takeaway from my talk will be that semen analysis is important test. However, it is very subjective, and therefore it is very important that all lab staff members are very well trained into conducting the semen analysis. Each lab must develop their own step-by-step protocol and not just follow the WHO manual. This is important that allows each and every technician to do the semen analysis correctly and expect the desired results. It's also important that the quality control is strictly followed, as Dr. Gupta illustrated, and each lab should also provide the physician with not only the addition that they are following, but also the reference ranges. And we hope that by adding or adopting these tests, the laboratory can provide correct information, the correct results to both the physician as well as the patient. Next slide, please. This is our andrology group, and I would like to thank you for your attention. Next slide, please. And this is a beautiful picture of one of our main building at the Cleveland Clinic. Thank you very much.
Thank you very much, Rakesh. Wonderful presentation on semen analysis. You covered a lot of areas here. So we'll continue. So I'm going to skip the introductory slide and jump directly into my talk on automated semen analysis. So we go directly to what we do here. Just in terms of the basic concept, a routine semen analysis is something that you have seen. It includes the macroscopic evaluation as well as a microscopic evaluation. You also heard from Dr. Sharma that this is the first test that is considered as the most essential by the physician when they are evaluating the patient for their male infertility. And you heard from Dr. Gupta how the semen analysis should be conducted using very strict quality control procedures, which is essentially a foundation for getting accurate and reproducible results. So what else we know? Semen analysis really is an important test, but is it simple? Not at all. It is a very complex test. It seems simple from the slides and the description that we provided, but to conduct it is extremely difficult. And why I'm saying it, because in this country, this test is actually classified as a high complexity test by the government, by Clinical Laboratory Improvement Act of the Congress. And it really it is regulated. All the andrology labs are regulated by the government, and they must perform quality control, quality assurance, and proficiency testing. The last two aspects are going to be discussed by Dr. Gupta again after my presentation. So let's see why is it so difficult to conduct. The most difficult part of doing a semen analysis is really because it is a subjective test. We are really looking under the microscope, trying to see the sperm which are moving around, zigzagging all over the field, and trying to count them while you are looking, and you don't know whether you counted them correctly. And then there are all kinds of abnormalities in terms of the shape that you're trying to evaluate as part of the morphology, which again is very difficult. But the difficulty of semen analysis are compounded because also of the biological variability that is there in the production of spermatozoa by the testis. The testis, when it is producing through the seminiferous tubule, the number of sperm cells that are released are not fixed. Sometimes they are low, sometimes they are a little bit high, sometimes they are very high. So if you recall the article in WHO, it shows the range from the same sample, from same individual collected over a course of 12 months. It can be as low as 15 or 20 million going all the way up to 200 million. And that is considered completely normal. And that is why it is prescribed, it is considered very, very important that to evaluate a man for their infertility, the 2 semen samples should be done, 2 semen analysis over a course of 2 to 3 months, at least 3 months apart. That only can provide the actual results which you can average to say that the person is normal or abnormal. And then there are various conditions with the methodology, the use of counting chamber, the sampling error, training experience, and trying to find the results. If you're doing it by the same person, on the same sample, we have found that it's very, very difficult to get the results which are reproducible. And let alone when you have multiple individuals working in a laboratory in a busy place, trying to conduct the testing, but to try to compare and see if their results are matching is a nightmare. So the more problems are there in terms of the results, then there are more errors in clinical decision making. Many times if the results incorrectly show that the semen sample has poor semen characteristics rather than a normal characteristic incorrectly, then the patient may be subjected to more invasive, more advanced ART procedures than trying to just go for an IUI. This is just one of many possibilities which can occur as a result of inaccurate semen analysis. Or if you have a varicocelectomy being performed, and after the surgery, when you're looking at the results of the semen analysis with inaccurate results, it may show that the results did not change, or the person did not improve in terms of the count, motility, and other characteristic, and that may force the patient to go for ART rather than try natural conception. So looking at all these conditions, we probably will not be surprised because the semen analysis includes a large number of steps. As you can see here, doing all kinds of physical checks, then doing the actual microscopic checks. There are almost 9 steps. And even in the best hands, it can take as much as 15 to 20 minutes. Persons who have been working in this and have a great deal of experience will not be able to do it faster than that because it will make a lot of mistakes. And then semen analysis is not complete. You have a morphology, which is the actual and essential part of a semen analysis evaluation. Using the fastest staining technique called DivQuick, you can see there are a number of steps from smear all the way to staining and then scoring of the slides. And it's almost 12 steps, which can take as much as an hour to your time to conduct the semen analysis. So this is a lot of time. And it's just a rule of thumb, more steps that are there are more possibilities of making a mistake. So to really circumvent these problems, which we know are present all over, there are a number of devices that have been developed by the industry over the last 40 years, and these are called computer-assisted semen analyzers. These are some of the various models that are available in the marketplace, and you can see, and some of you probably have seen these or maybe using these devices in your clinics or in your labs. These are the devices. All 3 devices are actually being used in our andrology labs. We have almost 6 or 7 such devices which we use day to day. So the factors that really impact these devices called computer-assisted semen analyzers are a variety of factors that can influence the sample preparation, whether a sample is well prepared or well mixed, frame rate, how many frames you are really taking when you are evaluating the sample for analysis, depth and type of sperm counting chamber that can result in mistakes or errors. Then the devices, CASA devices or computerized analyzers are traditionally inaccurate when the samples have high concentration above 80 or 100 million or low concentration below 10 or 15 million. So in general, all of these CASA devices have a really a big problem in terms of high or low concentration, and that affects the results of count, motility, and all the motion kinetic parameters such as velocity, linearity, etc. And then sperm agglutination can also interfere with the concentration, and same thing goes with the cellular debris. So these are some of the problems that are there. In terms of the advantages, of course, there are advantages, and that's why the laboratories really use. It's really a perfect system for busy laboratories where you want to improve the efficiency, you want to increase the workload, and you want the laboratory can conduct the test in a reliable, reproducible manner. These systems use special software to extract the desired information and produce the desired output. If appropriate protocols are followed, they can provide high precision and give quantitative data on sperm kinetics, which are the major advantages of these machines over manual semen analysis. So these are not, they definitely reduce the inter and intra-operator or within the technician or between the technician variability that we see is really a big problem with manual semen analysis can be circumvented with this device. And however, the devices are not automated. They are actually good in some sense, but they do have a large number of limitations. And the limitations are, they are really huge, they are bulky, they require a lot of training. So you cannot just walk from the park and say, well, I can do this analysis by sitting on this, and just it's really complicated. It requires a lot of training, understanding the protocol, understanding the settings, and doing it several times. So it is a complex process. And then there are variations in inter-operator results and requires quite a bit of time to complete the analysis. The most important limitations of these systems are they are very expensive. So it is really out of the reach of most of the laboratories, which are looking for inexpensive, accurate systems that they can incorporate in their clinics and in their laboratory to get correct results. So we are hearing, and you probably have heard, the artificial intelligence. It is really entering in every facet of our life. The technology is really racing, and it has really entered the human-assisted reproduction. There are so many AI-based or artificial intelligence-based technologies and algorithm in IVF which are already being used. There are companies like Genia, which makes Gary a time-lapse based device, which uses the morphokinetic analysis, uses the algorithm to assign a score to each embryo. Then Vitreous Health has Evie to identify the embryo with the best chance of achieving a successful pregnancy, and it's trained on time-lapse videos of thousands of embryos during their development. Then there are devices called Life Whisperer. It identifies morphological features that constitute a healthy embryo, trained on over 20,000 globally sourced 2D embryo images. Then there is PGTA, where AI applies to PGTA in the form of a machine learning approach for interpretation and reporting of next generation sequencing results to eliminate operator subjectivity. So you can see the advance of technology is really happening right in front of our eyes, and not in terms of very advanced things like cell phone and so forth, but in human-assisted reproduction where we all work. And really, I think the purpose is to really make the clinical decision system very, very predictive, make it cost-effective, and we can overall improve the rate of outcome and improve the outcome of ART. So taking these things in account, the andrology area is still slow to really gain a large number of such type of devices, although we know semen analysis is where I think we require the greatest support. I wanted to discuss about a new device called Lensuk Pro Semen Analyzer, which works on artificial intelligence optical microscopic based technology. This is one of the device that have come out into the andrology, at least to my knowledge. We haven't seen any other such device which is developed and available. Maybe they are in development, but they have not been introduced commercially into the marketplace for diagnostic systems. And this uses, it evaluates the semen based on WHO 5th edition, uses machine learning algorithm to avoid subjectivity to evaluate semen parameter, which is really what we are looking at. And on the right side is the report that it generates, and we are going to talk about that in a second too. So this is the system here. The device is really fully automated, which is what we all have been waiting. It involves just 3 steps. The entire analysis takes from A to Z 2 to 5 minutes. You get the pH, you get the concentration, the motility and morphology, and the measurement range of each parameter is really maximum according to WHO. pH from 6 to 8, concentration from 100,000 is pumped to 300 million per ml. Progressive motility, non-progressive from less than 1% to 100%, and morphology from less than 1 to 100%. So if you look on the bottom of the screen, the sample is basically 2 drops of the sample, one for the pH and one for all the sperm concentration, each of 40 microliter in volume is inserted in the cassette. And the cassette is then loaded onto the device, which is really small, just bigger than maybe your cell phone. And within 3 to 4 minutes or 2 to 3 minutes, it provides the results. And it provides all the values that you're looking. And to make it easy, I have a small video of 30 seconds where you can see. So it really is very quick in terms of its analysis. In terms of the quality control of all CASA systems, we need to do a daily precision, which is a daily quality control. It involves both low and high concentration of AccuBead to generate the Levy-Jennings chart, as you saw Dr. Gupta explain, and the results should be within the range specified for low and high AccuBead. If results are not within this range, defined percentage difference, the manual count or motility should be used, and you will need to recalibrate the CASA if problem persists. And we have conducted a study looking at the results of, we have conducted clinical trial using the Lensuk device, which I showed in the previous slide, and published in a peer-reviewed journal of our experience. And the results show very good correlation in terms of sperm count, sperm motility, progressive motility between the manual semen analysis and the results of Lensuk, as well as the results between the Lensuk and another CASA machine, such as the one from Hamilton Thorne called IVOS. So all in all, the results show very high degree of correlation, very tight CV or very good CV between the inter-observer and intra-observer results. However, there are some limitations of the system at this time. The sperm morphology results that we generate from this really don't correlate very well with manual semen analysis. The correlation is not very good. It cannot examine, the reason is that the machine cannot examine multiple fields, although it checks 100 grids. And also, it cannot examine acrosome region, although it can evaluate the shape from head to tail. However, the company is developing new algorithm, which in time will be able to examine morphology using stained slides in your model. So in terms of the advantages of this device, these are some of the advantages. It's very simple. I'm talking about lens hook. No training required. Anybody can use it without any kind of training. It's very, very small device. It takes only a few minutes to conduct. It's very accurate in terms of a range of concentration from 0.1 to 300. pH is provided along with the semen analysis. Morphology does not require any fixation or staining, although the morphology results are not very highly reliable at this time, but the accuracy of the results will change. A very good correlation between inter and intra-observer. And the most important part to me and for many others who are using this device is that results are available within few minutes. While the patient is waiting in the lab, while you are having the patient collect and provide the sample, the results are ready, and you can have these results given to the clinician, and they can discuss the results rather than asking that I will call you or the patient has to call back after 2 days or 3 days. This probably is the most important part, that you can really decrease the anxiety and the frustration and increase the efficiency of the entire process. You will have the results while patient is waiting. The clinician can discuss the results and provide what are the options for these couple for the next step. In terms of the take-home message here for my talk here, the most important part is that the new artificial intelligence optical microscopic device has a very high level of precision and agreement compared to manual semen analysis, even if it is conducted by a highly trained andrologist. The positive predictive value for X1 Pro is 100% for oligozoospermic samples and about 86% for asthenozoospermic sample, and that is very, very good. The results of X1 Pro correlate highly with the traditional CASA system such as Hamilton-Thorne, and which has been a market leader in the for a large number of time. So I believe that X1 Pro is a fast and simple device to operate that offers reliable and reproducible results. And this has been our experience. We have conducted a large clinical trial following our pilot study on more than 106 patients, and the results are being prepared for publication at this time. So thank you very much for listening to me. And this is our group at Cleveland Clinic in Andrology Center. And this is one of the images of the Cleveland Clinic. So our next presentation is going to be on quality assurance and proficiency testing in an andrology lab. And this talk is going to be given by Dr. Gupta and one of the technologists, if she is available, because we are actually a full-fledged open today for business. So our lab is actually servicing the patients. So some of the technologists who were involved in preparing and working on these talks are not able to join. Another technologist, Elisa Giroski, who actually helped prepare this talk, has a family illness also today, and she reported that she will not be able to join. So Dr. Gupta jumped and has taken over this talk. So Sejal, are you there? Can you begin the talk?
Yes, I'm there.
Okay.
So, morning, everyone, and welcome back once again. So I'm going to take it to the next level and talk about quality assurance in an andrology lab. And then the proficiency testing will be covered by the next speaker. Next slide, please. Learning objectives of my presentation are difference between quality control and quality assurance, implementing quality assurance within the andrology lab, quality assurance and its role in maintaining the lab accreditation, and what are the components of quality assurance. So this also applies on the right side. There is a depiction of the quality assurance cycle, it does apply to all three phases of testing, including pre-testing, testing, and post-testing. Next slide. So quality assurance in an andrology lab can be described as a systematic program that monitors and evaluates the quality of services, which is provided to infertile couples and their treating clinicians. And there is a purpose for quality assurance in the laboratory as well as a need. So the purpose is to provide reliable and efficient services of the lab, maintaining the highest quality and complying with regulatory requirements. And the need is that it is required by accreditation, CAP, and FDA, and ultimately produces results that have applicable diagnostic, health, and healthcare decisions. Next slide. So what are the essential differences between quality control and quality assurance? So on the left are the descriptions for quality control. I would like you to note at this point that quality control activities do not measure the laboratory performance as a whole. Quality control treats each element as a unit, whereas quality assurance, on the other hand, is the overall surveillance of all laboratory activities related to quality. It includes measuring the entire testing process. It includes monitoring the outcomes. It includes reporting accurate results and assessment of feedback from patients and the various personnel. So the bottom line is quality control is a part of quality assurance. Next slide. How do we implement the quality assurance program within the andrology lab? So we have certain defined objectives. The quality control plan, quality assurance plan is defined to organize and monitor the processes and procedures within the lab and identify any problems or errors and document them, as well as perform a review of these errors or deviations that have happened within the lab. And this is an ongoing review which involves the pre-analytical, analytical, and post-analytical phases. So within our laboratory, we have a review that we conduct by doing self-assessment audits. So as part of the self-assessment audits, we have a QA weekly report audit, wherein the patient worksheets are picked up at random, and these are reviewed for errors, and then these errors are documented. And I will provide an example as we go further in my presentation. We also have a monthly quality assurance or quality improvement review report, which is a comprehensive review of the test results, the sperm inventory checks, the test turnaround times, and also review of the incident reports. Next slide. Next slide. So this is an example of documenting errors, and this is an actual worksheet from a test that has been done in the andrology lab at the Cleveland Clinic, and this is reviewed, checked for any errors, checked for calculation errors, and once everything is checked and documented, the supervisor will sign off, as you can see on the right upper hand of this sheet. Next. And then checking of the electronic medical records, which is shown over here, printed from the EPIC systems, and all of the results have been checked and documented. Next. So here I provided an error report. This is a weekly report that has been done, and the days when there were no errors, it has been documented, the type of the test conducted, there is a description of the test, and whenever there is an error, you can see in row 4, there was an error in the pre-wash calculations, and this was documented. And the correction of the error is also documented. So this is a weekly audit that we do as part of quality assurance. Next. Any incident or accident or error or deviation is recorded as a lab occurrence report. This is part of our quality assurance. So this is a very detailed form which looks at the pre-examination, examination, and post-examination phase. And here, the factual description of the incident, you can look at the lower box, and it provides that the IUI process was canceled because of lack of enough number of motile sperm, as observed in the wet prep. Next. So this is the second part of the occurrence report. What was the corrective action taken? The incident was reported to the reproductive endocrinologist, and then she informed that the sample should not be processed because of the low numbers. And then she counseled the patient and informed him because the sample was rejected and the procedure was not carried out. And then finally, we also have tick mark in the box as showing that this incident was corrected, the date of correction, and then this is reviewed by the supervisor and the director. Next. We also have for the instruments, any incident or deviation in the instrument quality indicators is documented as an instrument maintenance report, including all details of the instrument and what was the problem. So here we have a problem with one of the pipette guns, which was not charging, and then the supervisor contacted the clinical engineer, and then he examined the machine and recommended it sending to the manufacturer. Next. Next slide. So here we have shown that the manufacturer was unable to repair, and then we had to trade in for a new instrument. So instrument problems are documented, and the resolution is documented in this report. Next. So this is the overall quality assurance report, which is prepared for all the processes within the lab. It includes the IUI sperm prep reviews, the sperm cryopreservation reviews, and also performing frozen sperm samples inventory check. I just want to provide one example to, you can examine the IUI sperm prep in the top box, which gives the threshold for recovery rate as greater than 10%. So all of the three samples that were processed within our lab met this criteria. If the criteria are not met, then we document it and go back and look at what the root cause was of the poor recovery rate and provide a resolution. Next. So this is continuation of the QA report, and this shows the turnaround times. And here, one of the turnaround times was not met because the threshold was 3 to 5 days, and it is 8 days. And then we went back and investigated why this happened. Next. So this is documented, the problem area is identified. The correction was that the semen analysis results were entered and submitted in the system. And then we went back and looked at several other tests that were performed to look, to examine if the turnaround times were higher, and these were within the expected range. And this was a random incidence. So basically, we looked at all the processes, made sure this was not happening repeatedly, and provided a resolution. Next. So quality management report is an integration of all the processes within the lab. It includes quality control reviews, quality assurance reviews, error reporting, any specimen rejections, the proficiency, and the competency. So this is a more wholesome review of all of the services that we are providing within the lab, and this is prepared by one of the supervisors, and any deviations or non-conformities are documented. Here, there was no deviation, and then this is finally reviewed by the director and signed off. Next. Quality assurance is important for maintaining the lab accreditation, and this is per the Code of Federal Regulations, which is the FDA. They require that the lab follow the written policies and procedures for a comprehensive QA program, and it is designed for and ongoing assessment. And this also is a requirement on the right side. You would see, as per the Clinical Laboratory Improvement Act of CLIA, which includes these two regulations per the federal regulations, also includes looking at the test results, staff competency, and documenting all the quality assurance activities. Because whatever is not documented is not performed. And then the CLIA designates the College of American Pathologists to come and inspect the labs and look at all the documentation. And once they are satisfied, they will accredit the lab. Next slide, please. So these are the standards per the CLIA. On the right side, the 10 standards are provided by CLIA, and which are part of the quality assurance plan which the lab implements. And each laboratory implements this QA program based upon patient test management, quality control, and all of the other pillars which I have explained in my talk earlier. Next slide. So the take-home message is the main objective for implementation of a quality assurance program is to maintain, document, and review any problems that may occur in the andrology laboratory, not limited to just the test problems, but even any complaints or patient feedback, as well as the physician feedback. And this is important for the labs to stay compliant. And each lab can actually have a QA review committee. And this quality assurance reports that are generated can be reviewed based upon the available information. And then any problems can be researched and solutions can be provided by the laboratory staff and suggest actions to be taken to maintain and improve, as well as achieve high standards of performance and service in the andrology laboratory. Next slide. So now the next part of the presentation will be done by Dr. Sharma. He's going to be speaking about proficiency testing in the andrology lab.
Next slide, please.
Courtney will not be here today. I mean, she is here, but she is busy with taking care of some of the patients in our other lab because of the shortness, because several of the staff, employees have some family issues. So don't think Courtney is a very beautiful woman, but the next speaker is not Courtney Sharma. So please don't be confused with that. All right, Rakesh.
Thank you, Dr. Agwal. So I'm going to cover the proficiency testing, and Dr. Gupta has covered in detail the quality control, the quality assurance, and the last section is proficiency testing. So the objectives I will cover is some of the principles of proficiency testing, why participate in such a testing program, and the analytes that our andrology lab participates, and then some key takeaway points. Next slide, please. Next slide, please. So as the name suggests, proficiency testing. So I want to draw your attention. Proficiency, as the name suggests, is do you have the skill or the ability or the expertise to conduct the tests that are offered to the patient? In other words, is the laboratory technologist proficient or capable or skilled to conduct the test? And that is, in simple terms, the proficiency testing. And the objective is to have a test which is reliable and we can validate the testing process. And the accreditation agencies such as CAP or the College of American Pathologists conducts this proficiency testing semi-annually, and the lab will order the survey material or the test material based on the test that they conduct. And in our andrology lab, we perform the sperm concentration, we perform the sperm motility, morphology, the vitality, and the antibodies. So those are the survey material that we will order from the testing agency. The survey material is received twice a year, and the lab will designate a person or a technologist to conduct the test, and the test results are then reported to the testing agency, which will then provide us the review or the report of the proficiency testing, as you can see on the image onto your right. And based on that, we will be informed whether the person who conducted the test has passed those analytes and the lab is good for the proficiency testing for that duration of time. Next slide, please. So some of the principles of proficiency testing that we should keep in mind is number one, there is no laboratory communication, and if the lab has multiple labs around the city, then they cannot communicate those results within their lab as well as in other labs. The communication of the result is strictly prohibited, and the survey material is analyzed as we would analyze a regular patient sample. And in our andrology setting, we designate one technologist who analyzes all the analytes or all the survey material obtained from the proficiency testing agency. The results cannot be discussed with the other lab personnel before the material is sent to the testing agency. And once the results are obtained, these results are discussed among the lab employees, and if a corrective action is required, then that is implemented. All the results from the survey material must fall within the mean on 2 standard deviation. On to your right, to see a picture of our team looking at the semen analysis. Next slide, please. So our lab orders the analytes, which I mentioned are the sperm concentration, and the testing agency will provide us 2 analytes, and generally they are the low and high concentration of sperm. We load the sample onto the sperm counting chamber, and the 6 microliter sample is loaded, as I explained in my earlier presentation. And the testing method that is reported is the fixed cell concentration method, and these results are reported to the agency whether the sperm were present in that particular analyte or they were absent, and the results should be within 2 standard deviations of the established results by the testing agency. Next slide, please. The other analyte that we order is the sperm motility. So the testing agency provides us access to the video clips, and these are online links. We examine the 2 analytes. They could be low motility and a high motility, and we also report the percent motility as well as we calculate the forward progression when we're reporting the results back to the testing agency. Next slide, please. In addition, the other analytes are also tested, as I mentioned, the vitality or the morphology or the antibodies, and all these results are then compiled by the testing agency, and we will receive the results, as you can see in the box onto your right. And the results of the lab that provided the analyte results are indicated. Also, the results of our testing are provided with the mean and the standard deviation. We also are informed of the number of participating labs, and it also provides information whether the lab has passed that particular analyte. In many cases, the testing agency will report a value of 26 as a grade, and what this means is that the results are not indicated in the result by the testing agency as pass or fail, but this is reviewed by the lab director, and if the results are acceptable, then each technologist will sign off, and that indicates that the lab has passed the proficiency testing. Next slide, please. So the take-home message from the proficiency testing is that in order for the lab to be certified or accredited, we are required to participate in the proficiency testing, and this is done twice a year. And the analytes that are ordered are based on the tests that are conducted. The number of tests that we are conducting are the defining criteria of the analytes that we will request from the testing agency. And if the results are within 2 standard deviation, then no further action is required and the lab has passed the proficiency testing. In situations where the particular analyte may not fall in the acceptable category, then the remedial measures are in place. And if the repeated failures are noticed, then the lab must stop testing. So to sum it up, proficiency testing is very important and a part of the quality control and quality assurance, which provides the confidence in the test results that are provided by the lab to the patient as well as to the physician. Next slide, please. This is a group, again, looking at some of the setup of the semen analysis in a micromanipulator. Next slide, please. Thank you very much for your attention. And this is a beautiful sunny day showing one of our Cleveland Clinic buildings. Thank you again.
Thank you very much, Rakesh, for your presentation. We now move along and go to our last presentation. So the next presentation is by our colleague, Dr. Neil Parekh. Neil is a urologist who specialized in male infertility. He did a fellowship here at Cleveland Clinic in our department, and he is now on his staff of the Cleveland Clinic Department of Urology. And he has a major practice in male infertility, and he is going to be actually discussing the interpretation of lab results in the clinical management.
Hi everyone, my name is Dr. Neil Parekh. I am a clinical assistant professor in male infertility and andrology at the Cleveland Clinic. I have the opportunity today to discuss the clinical interpretation of the semen analysis. Unfortunately, I wasn't able to be with you live today, but I look forward to sharing my thoughts throughout this presentation. I'm going to begin the lecture by discussing the first step in the specimen collection, and that begins with counseling patients on the appropriate abstinence interval prior to their semen collection. Now, the appropriate abstinence interval should be a period of 48 hours, but not more than 7 days. There is some evidence to indicate that an abstinence interval greater than 7 days may result in higher levels of sperm DNA fragmentation. Next, the sample should be obtained via masturbation. If the sample is collected off-site, the patient should deliver it to the lab within 30 minutes to 1 hour, and it should be kept at body temperature during transport. Patients should be counseled to avoid lubricants during the process, as they can be spermaticidal. And finally, coitus interruptus is not an acceptable means of collection, primarily because the first portion of the ejaculation has the highest concentration of sperm, and that will be lost, and the vaginal fluid has an acidic pH that can adversely affect sperm motility. The remainder of the lecture will be broken up into a number of clinical questions. Our first clinical question today is, what do you do if the patient presents with a sample that is in pinkish color rather than opaque in color? This is a fairly common condition called hematospermia. Now, hematospermia may indicate red blood cells in the ejaculate, as opposed to the normal gray opalescent color of the semen. You may have a pinkish or brownish color. Now, the first step is typically to reassure the patient. I commonly see patients who present with a history of trauma, whether it was through sexual activity, riding a motorcycle, or an injury to the perineal area that resulted in the hematospermia. Other causes may be iatrogenic, such as a prostate biopsy, or infection, inflammation, or a number of bleeding disorders. Patients should be reassured that the hematospermia will likely clear after several more ejaculations, and the specimen can be recollected if needed. Second clinical question is a patient who presents with low semen volume, less than 0.5 mLs, after the 48-hour recommended abstinence period. Now, of course, the first step is to ensure that the patients complied with the abstinence interval, and two, to make sure there was no problem with the specimen collection. Now, the specimen collection can be a difficult or awkward scenario for many men, so we want to make sure that the specimen was collected completely in the cup and nothing spilled out, and to ask if the specimen was a normal volume that they see on a day-to-day basis, or if there was any difference in the volume of this particular ejaculate. Once you have ruled out those issues, it is important to know that the majority of the fluid from the ejaculate arises from the seminal vesicles. So that's over 70% of the ejaculate volume is produced by the seminal vesicles. Less than 10% of the ejaculate volume actually arises from the epididymis or the testicle. So low volume can be attributed to an obstruction of the ejaculatory duct or hypoplasia of the prostate and seminal vesicles, congenital bilateral absence of the vas deferens. A common issue is retrograde ejaculation, particularly in our patients with diabetes. It is important to counsel men with diabetes that poor control can affect the bladder neck and thereby result in retrograde ejaculation. And also, you should review the medication list for these patients, as a number of medications that are commonly used, such as alpha blockers, such as tamsulosin, can result in retrograde ejaculation. Previous surgical history should also be elicited, as surgery on the bladder neck or prostate can result in bladder neck damage and retrograde ejaculation. A history of neurologic or spinal cord injury or issues can result in failure of emission. And finally, testosterone deficiency or androgen insufficiency can also result in low semen volume and can be tested for through laboratory blood work. Our third clinical question is, what if a sample is very viscous and does not liquefy after 60 minutes? Now, it is controversial, but some studies indicate that increased viscosity may impair motility and thereby fertility. The cause for this is the prostate secretes a proteolytic enzyme called fibrinolysin. This is what facilitates the liquefaction process. Now, if there is prostate dysfunction, frequent ejaculation, or an ejaculatory duct obstruction, this can impair the secretion of fibrinolysin and thereby affect the viscosity. All right, so our fourth clinical question is a patient with normal semen volume, but there is no sperm seen in the ejaculate. This is a condition called azospermia. Azospermia is defined as the complete absence of sperm after examination of a centrifuged pellet on two separate occasions greater than 2 weeks apart. If this is confirmed, the next step is to determine whether this is obstructive or non-obstructive azospermia. Non-obstructive azospermia can be broken down into pre-testicular causes, which are primarily hormonal, such as hypogonadotropic hypogonadism, such as Kallmann syndrome, or testicular, where there's an intrinsic problem with the testicle, whether that be genetic, environmental influences, a varicocele, cryptorchidism, etc. Now, an obstructive azospermia is considered post-testicular cause of azospermia and is more likely an obstructive process, such as ejaculatory duct obstruction, a history of vasectomy, or a history of infections, which can lead to scarring and ultimately obstruction. Here we have a flow chart that can help elicit or determine the type of azospermia. So on initial exam, both vas deferens should be palpated. If there is absence of the vas deferens, you should investigate further with CFTR gene mutation in both the husband and their partner. If there is the vas deferens present bilaterally, you should look at the semen volume on the semen analysis. If it is a low semen volume, you should assess for retrograde ejaculation, and that is done by assessing for sperm in the urine. If there is no evidence of retrograde ejaculation, the next step is to perform a transrectal ultrasound to evaluate for ejaculatory duct obstruction. Now, if the patient presents with normal seminal volume, we typically use the testicular axis and the hormone FSH to help identify the cause. And testicular axis of greater than 4.6 centimeters and a follicular stimulating hormone level less than or equal to 7.6 has a sensitivity of 96% in identifying obstructive azoospermia. However, a testicular axis of less than 4.6 with an FSH greater than 7.6 is more predictive of non-obstructive azoospermia. Now, an entire lecture can be dedicated to the diagnosis and management of azoospermia, but for today's lecture, we'll have to just stick with the basics. Now, question 5, normal volume and motility, but sperm concentration is low. So this scenario, the definition of low sperm concentration less than 15 million is defined as oligozoospermia. Now, the AUA, ASRM, and the EAU all recommend an endocrine evaluation in men with oligozoospermia. The minimal hormonal testing should be testosterone and FSH. However, you can include a number of other tests, including TSH, LH, prolactin, etc. Genetic evaluation is also recommended by these organizations for men with severe oligozoospermia, so a sperm concentration less than 10 million. Now, what are causes of oligozoospermia? This can arise from a varicocele, an infection or inflammation, retrograde ejaculation, a history of malignancy, particular testicular cancer, a history of undescended testicle or cryptorchidism, hormonal issues, genetic mutations, prior pelvic surgeries, particular medications, or a history of chemotherapy or radiation. Once a cause can be identified, then appropriate testing management can then be performed. Clinical question number 6 is a patient with normal semen volume and concentration but low motility. The WHO defines normal total motility of being greater than 40%. So motility less than 40% is defined as asthenozoospermia. If motility is less than 0% or near 0%, we commonly perform vitality testing to differentiate between necrozoospermia or asthenozoospermia, which is viable immotile sperm. Now, we'll have a lecture later on in this series dedicated to specifically talking about specialized testing, such as vitality testing. In this patient, where motility is less than 20% or even less than 10%, we can sometimes attribute ultrastructural defects in the reproductive tract as a cause for the low motility. Clinically, we commonly counsel patients using the total motile sperm count, which is a combination of the total semen volume, the concentration, and the motility. Using the total motile sperm count, we have found this to be more predictive of predicting natural conception rates as well as success with assisted reproductive techniques. The last clinical question is a patient with low concentration and poor motility, less than 10%. Once again, the causes of oligozoospermia are listed here. Appropriate clinical history, physical exam, blood work, imaging may need to be required to assess for the possible causes of this condition, which is oligoasthenozoospermia. In conclusion, we have gone through a number of different macroscopic and microscopic components of the semen evaluation, which are a critical and important part of the male fertility evaluation. Now, there can be significant variability among semen analysis, as we know, but appropriate patient counseling prior to collection and a clear understanding of the various components of the semen analysis is essential for the proper evaluation and management of male subfertility. Thank you.
So to very quickly summarize what we covered in this module 1A on semen analysis, is the laboratories engaged in conducting semen analysis, whether they are part of IVF or whether they are part of andrology, should follow specific guidelines to protect themselves and their patient against COVID-19. These are not difficult guidelines. These are the ones that you saw in today's presentation are basically the things that we have been told by the WHO or by other organizations all over the world. We must understand the principles and procedures for collection and delivery of semen samples, because that is the bedrock of how correct analysis can be conducted. We have to enforce a strict quality control in the andrology testing to produce reproducible semen analysis results. So this is the key. We all heard that manual semen analysis is really highly subjective, even though it is considered by the WHO is the most important test. The things that we need to do to make it reliable is to implement quality control. We need to use the WHO 5th edition reference values. Even with the shortcomings that are there, we heard from Dr. Sharma, we still have to use these guidelines until the new set of guidelines are released by the World Health Organization in the form of 6th edition. The quality assurance is really an indicator of how well we are performing overall within the laboratory and what we need to do to improve the processes that will really improve the overall results and level of satisfaction among our physician and for our patients. And this is also a requirement for accreditation agencies, at least in the United States. We heard about the importance of proficiency testing and why it is important, how to conduct it, what are the requirements, and these are very important in the context of andrology laboratory, which are performing high complexity testing. You heard from the last lecture by Dr. Neil Parekh, the interpretation of lab results. This is important for all of us to understand, because ultimately the results that we are generating really make a difference in how these patients are going to be evaluated and how they are going to be actually treated. So the results are really the foundation for the treatment that will be taken up by the clinicians. So we need to do a very good job in terms of conducting a proper and reliable results semen analysis and provide really the parameters which are reliable and that can be used by the clinician to characterize what kind of treatment may be necessary. So this is really the foundation. Now, I want to talk to you and introduce our next learning platform, which will be in December, after a month, on December 8th. And the subject of this topic is sperm morphology. And we are going to post it on LinkedIn in terms of this particular program. So this is going to cover all areas of sperm morphology, which is extremely important aspect of semen analysis, but could not be covered within this presentation. The speakers for our morphology will include Professor Henkel, Dr. Gupta, Dr. Sharma, and Dr. Neil Parekh. And you will see the program will be released on LinkedIn either today or tomorrow. So I want to again thank you, all our speakers here. Some of our lab technologists who were supposed to speak and give some of the talks could not do it because of certain emergencies within their family. But they really worked very hard to prepare these presentations, such as on quality control, such as on quality assurance, proficiency testing, etc. And I want to thank also a special group of our coordinators, which we introduced in the first slide, Dr. Sarah Madani, Camila Pompeu, Dr. Neha Singh, Sarah and Masa Darbandi. I can never tell because they are twin sisters. and then Andrea Bello, who was supposed to join, but she had a family emergency and she could not join today, and Raha Sadegi and Dr. Renata. A special thanks goes to Dr. Dama, Dr. Damayanti from Malaysia for creating online survey. I'm sorry. And also to our team of two IT professionals here, David Reichling and David Wolfley, for providing the webcast services. So these are the people who helped. Now I want to provide you the link for the multiple choice exam, which is given here. You can copy and paste, but also we are going to copy and paste on the chat. So you will be able to copy it and start the exam. You also have the link to the online survey, which is in the second, and also the link for registration for module 1B.